Good afternoon, dear students. I am Pronevich A.V, Department of Polyclinic Therapy, and today is our topic, differential diagnosis of urinary syndrome, treatment of chronic pyelonephritis, glomerulonephritis, and chronic kidney disease. Urinary syndrome, what does it mean? Urinary syndrome is a combination of proteinuria, hematuria, leukocyturia, and cylindruria. Hematuria. Visible hematuria is most likely to be caused by a tumor, which can affect any part of the urogenital tract. Non-visible hematuria may also indicate underlying tumors, glomerular bleeding, occurs when inflammatory, destructive, or degenerative process described the glomerular basement membrane. Permanent passage of red blood cells in the urine. Patient with visible or non-visible hematuria should be also be assessed hypertension, proteinuria, reduced or declined renal function, family history renal disease, or features of a systemic disease. In a history, we can see blood clots, other source of bleeding, GI, hepatitis, fever, stringent exercise, urinary tract infections such as dysuria, frequency, last menstrual period, past medical history. It can be tumors, renal stones, cysts, kidney disease, lupus, Alport syndrome, medicamentation, acetylsalicylic acid, NSAIDs or anticoagulants. Urinary syndrome that include proteinuria is usually asymptomatic and is often picked up by urinalysis. Also, large amounts of protein may make the urine fuzzy. Transit proteinuria can occur after vigorous exercise, fever, and heart failure in people with urinary tract infection. In a history, you can see ankle swelling, fever, strenuous exercise, urinary tract infection, dysuria frequency, past medical history. It can be myeloma, diabetes, glomerulonephritis, lupus, medications, the same antibiotics and NSAIDs. Cylindruria. Urinary extension. It's called cylindra, protein or aggregate having a cylinder shape and different lengths. It can be hairline, granular, waxy, erythrocyte, leukocyte, and pigment. On this picture, we can see the reasons of proteinuria hematuria. Proteinuria, it can be reason minimal change in nephropathy. It can be focal and segmental glomerulosclerosis, membranous nephropathy, amyloid, diabetic nephropathy. It can be mesangiocapillary glomerulonephritis, post-streptococcal glomerulonephritis, small vessel vasculitis, anti-GBM disease. It can be and for characteristic and for proteinuria hematuria can be SLE, lupus erythematosus. Hematuria reasons can be AGA nephropathy and the disease what I said before. So the mechanism of action we can see it can be nephrotic and nephritic syndrome. For nephrotic mechanism is injury to deposits, podocytes, change in architecture, swelling deposit of matrix and other elements. For nephritic mechanisms can be inflammation, reactive cell proliferative, and break in glomerulus, distance formation. Chronic pyelonephritis. What it means? Chronic pyelonephritis is a chronic, non-specific inflammation in the interstitial tissue in the kidney, leading to damage of the mucous membrane of the pelvis, renal vessel, or parenchyma. An acute process can turn into chronic due to a number of reasons. Violation of the flow of urine due to the presence of stones and narrowing of the urinary tract. Vesicular or ureteropervical reflux of urine, inflammatory disease of closely located organs, urethritis, cystitis, prostatitis, appendicitis, enterocolitis. General diseases, immune deficiency, diabetes, obesity, chronic intoxication, smoking, alcohol abuse, occupational hazards, untimely and inadequate therapy of acute pyelonephritis. For classification, first, by the presence of previous organic causes. primary chronic pyelonephritis and secondary. Primary, there is no inorganic reasons for the violation of aerodynamics. The inflammation process develops over healthy kidneys and as a rule is bacterial. Secondary pyelonephritis is develops against the background of the previous lesion of the urinary tract. Finding out the organic causes is very important for treatment. This is an obstruction. You must first restore the flow of urine, so surgical treatment. And if chronic pyelonephritis is can be unilateral, but after several years of the disease, a second kidney is also affected. Bilocalization, it can be pyelonephritis from one side, unilateral, or pyelonephritis bilateral, more often. According to the phase of inflammatory process, phase of active inflammation is symptoms of pyelonephritis and laboratory abnormalities. And phase of latent inflammation, it can be only laboratory test reaction. So there is no symptoms of pyelonephritis. It may be increased fatigue, suprainferior condition in the evening, and 50-13% of cases chronic pyelonephritis has no clinical manifestation. And remission phase. Remission phase is within 5 years chronic pyelonephritis, had no exacerbation, so we can talk about recovery. According to severity, uncomplicated pyelonephritis and complicated pyelonephritis. Complicated pyelonephritis includes nosocomial infection, secondary chronic pyelonephritis, that one is anatomical changes, urolithiasis, prostatitis, chronic pyelonephritis that develop after logical manipulation, cauterization, and can be of metabolic or hormone disorders, diabetes mellitus, chronic renal failure, immunodeficiency patients, HIV infections. If is a patient with diabetes mellitus and he has chronic pyelonephritis, which is a complicated urinary tract infection. All urinary tract infections in men are usually complicated. According to by the presence of external manifestation. So it can be secondary parenchymal arterial hypertension, or it can be anemia. According to degree of impaired renal function, it's stage according to chronic renal failure. Pyelonephritis treatment. Antibacterial therapy, dorhinolones, cephalosporins, nutrafurans derivation. It's we can use after culture for microflora. Non-steroid anti-inflammatory drugs, combined herbal medicines, 21-day, chronic obstructive pyelonephritis, treatment of the underlying disease, urolithiasis, gydropyelonephrosis, benign prostate hyperplasia, neurogenic bladder, and ureteral structure. Glomerulonephritis. While glomerulonephritis literally means inflammation of glomeruli, the term is often used more broadly to describe all types of glomerular disease, even though some of them, minimal change in nephropathy, are not associated with inflammation. Most types of glomerulonephritis are immunologically mediated in several response to immunosuppressive drugs. A deposition of antibodies occurs in many types of glomerulonephritis, and testing for circulating or glomerular disposing of antibodies may aid diagnosis. In small vessels vasculitis, no glomerular antibodies deposit is observed, autoimmune, but the antibodies may be ineffectively pathogenic by activation of neutrophils to promote the talar injury. Clinical variants of chronic glomerulonephritis. Latent form. It's 54%. Isolated urinary syndrome, sometimes moderately hypertension. It can be slowly progressive course. A chronic glomerular failure will be in 15-20 years. Morphologically, it's a mesenchymal and membranous glomerulonephritis. Hematuria form 6%. Hematuria with episodes of gloss hematuria. The course is variable with late development of chronic renal failure. hypertension form, 20%. In women died by hypertension, changes in urine proteinuria up to 1 gram per day, microhematuria, morphological mesangioperipheric and membranoproliferative. Nephrotic form, 20% of course. Severe edema, massive proteinuria, decreased diuresis, microalbuminemia, hyperangiobulinemia, hypercholesterolemia, hypertriglyceridemia, increased blood pressure. The course is usually moderately progressive, and during the period of remission, the syndrome persists. Morphologically, is membranous, mesangioperipheric, and mesangiocapillary. With the development of chronic renal failure, the severity of nephrotic syndrome decreases, the potential commons of the four. Mixed glomerulonephritis is a combination of nephrotic and hypertensive form. The most unfavorable form, mesangiocapillary glomerulonephritis, rapidly progressive course, chronic kidney disease in 2 to 5 years. Patient examination algorithm, chronic glomerulonephritis. Urinary test. Total daily proteinuria, and weakening electrophoresis and immunoelectrophoresis of urine proteins. Complete blood count with reticulocyte count. Biochemical blood, creatinine level, urea, protein fractures, lipid spectrum, electrolytes. Coagulogram. CSO, the glomerular filtration rate. Antineutrophil, cytoplasmic antibodies, complement, circulation immune complex, antibodies to the basement membrane of the kidney. Examination of viral hepatitis B, C, HIV infection, anti-staphylococcus O, antinuclear antibodies, preglobulin ultrasound of the kidney and urinary tract, CT, MRI, echocardiogram, blood test for sterility. Examination for exclusion of invisible paraneoplastic syndrome is malignant neoplasm of the respiratory system, urinary system, gastrointestinal tract, thyroid gland with lymphogranulomatoses and multiple myeloma. Clarified method of diagnosis is the puncture biopsy of the kidneys. This is the pathology of glomerular disease. Under A, picture we can see normal glomerulosis. B, it's focal segmental glomerulosclerosis. C, focal necrosis glomerulonephritis. D, membranous glomerulonephritis. Crescent, it's E, glomerulonephritis. F, membranous glomerulonephritis. G, IgA nephropathy. H, anti-GBM disease. Categorized by clinical presentation and histological classification. According to histology, it can be nephrotic presentation, mild glomerulonephrotic presentation, and rapidly progressive glomerulonephritis presentation. In nephrotic presentation, it can be minimal changes, good response to glucocorticosteroids, and dominant cause of idiopathic nephrotic syndrome in childhood. Focal segmented glomerulosclerosis, less responsive to treatment than minimal changes, may progress to renal impairment and can recur after transplantation. And membranous nephropathy, may respond to glucocorticosteroid and immunosuppressant therapy. Immunoglobulin A nephropathy. It's a common disease range of presentation, usually including hematuria and hypertension. Mesangiocapillary. No prevent treatment. For focal necrosis glomerulonephrosis, it can be response treatment with glucocorticosteroids and immunosuppressants. For diffuse proliferative glomerulonephritis present with severe sodium and fluid tension, hypertension, hematuria, oliguria, usually resolved spontaneously. Antiglomerular basement membrane disease. Treatment with glucocorticosteroid, cyclophosphamide, and plasma in charge. Chronic kidney disease. What it means? Chronic kidney disease is defined as abnormalities of kidney structural function present more than 3 months with implication for health. Chronic kidney disease is classified based on Kerr's glomerular filtration category from 1 to 5 and albuminuria category from 1 to 3. Chronic kidney disease refers to an irreversible deterioration of renal functions that usually develops over a period of years. Initially, it manifests only as a chemistry abnormalities, but it can be loss of the excretory, metabolic, endocrine function of a kidney leads to the clinical symptoms and signs of renal failure. Collectively refers us to uremia. When death is likely without transplantation, it's the last stage 5, so-called end-stage renal disease. Here we can see physical signs for chronic kidney disease. We can see the pair of skin, yellow compression, irregular venous pressure, rise in the fluid overload, or radical tamponade. We can see the pericardial fracture up. It can be breathing easily. It can be increased respiratory rate in death and metabolic acidosis. Peripheral neuropathy, absence reflexes, reduced sensation, restless legs. Stages of chronic kidney disease. It's 5 stages. First, kidney damage with normal or high glomerular filtration rate more than 90. Normal function and clinical visitations asymptomatic. Second, kidney damage and glomerular filtration rate from 60 to 89. It's mild chronic kidney disease and clinical presentation asymptomatic. Stage 3A, glomerular filtration rate 45 to 59. It's a mild to or moderate chronic kidney disease, usually asymptomatic. Stage 3B, glomerular filtration 30-45. Moderate to severe chronic kidney disease. It can be present anemia in some patients, and most are non-progressive or progressive very slowly. Stage 4, glomerular filtration rate from 50 to 29, severe chronic kidney disease. First symptoms often at glomerular filtration rate less than 12. Electrolyte problems. Stage 5, glomerular filtration rate less than 15, or it's dialysis, kidney failure. Significant symptoms and complications usually present. Dialysis infiltration varies, but usually glomerular filtration less than 10. According to albuminuria, we can see current chronic kidney disease and include A1, A2, A3. A1, it means that albuminuria less than 30 mg per gram. A2, moderately increased. It's albuminuria from 30 to 300 mg per gram. A3, it's more than 300 mg per gram. And green, we can see that green is low risk, is no markers of kidney disease. Yellow, it's moderately increased risk. Orange, it's high risk. And red, it's very high risk. Treatment of chronic kidney disease. Drugs that improve renal hemodynamics, oral antiplatelet agents such as dipyridamole or pentoxifylline orally. Symptomatic arterial hypertension, ACE inhibitors or an angiotensin II receptors agonist or calcium channels agonist or beta blockers orally, or add alpha blockers or selective imidazoline receptor agonist, moxonidine. Syndrome of uremic intoxication, sorbents in course of 1 week per month. Correction of acid-base balance, acidosis, sodium bicarbonate inside 1 gram per day. Anemia syndrome. Recombinant erythropoietin alpha. It can be oral and should be iron preparation, lipid metabolism disorder, lipid-lowering drug statins, hypertriglyceridemia, fibrates, phenofibrate, urogastropathy, drugs used in inhalation as secretory function, stomach proton pump inhibitors, edema syndrome, diuretic therapy, furosemide and otiazide, spironolactone and dopamide. In chronic kidney disease stage 1 to 3, Diazide diuretics can be used in a stage 5 and 4. Spironolactone is contraindicated due to hyperkalemia. In a stage 5, only loop diuretics are indicated. These options for renal replacement therapy. It's picture A is hemodialysis, blood to patient, blood from patient, and dialysate. Picture B, hemofiltration. Picture C, peritoneal dialysis, and last is D, transplantation therapy. This is a patient used for last stage of chronic kidney disease. Usually it's chronic glomerular filtration rate less than 10. Renal colic. Renal colic. It's an attack of acute pain that occurs in acute obstruction of a urinary tract. Causes of renal colic: erythrolysis, pyelonephritis, trauma, tumor, a kidney or bladder, aneurysm of the urethra. Violation of the outflow of the urine from the kidney due to obstruction of the urinary tract stone, blood clots. Leads to increase on intra-arterial pressure. It causes tetanus, renal capsules reach pain receptors. Manifestation of renal colic: pain in the lumbar region or the protection of the urethra. Distortion in the pain depends on the level of obstruction: the upper third of the urethra, the average area of the abdomen, the middle third of the urethra, the groin, and the osteocytes. Lower third is genitals. Painful urination, frequent urination, chills, fever, nausea, and vomiting. What complications? It can be pyelonephritis, hydronephritis, and uremia. For medical tactics, emergency care, we should use intravenous metamizole 30% solution, 2 milliliters. Is absent effect, we can add atropine under the skin and use spasmolytic therapy. It's a main intravenous dotavirine, a 2% solution, or and ketorolac intramuscularly. This all according to urinary syndrome. Thank you for your attention. See you on our classes. Goodbye.